I have a 15-year-old. We are a few months in now with primarily me teaching him how to drive. And to me, there were some things I've learned in reading about learning models, teaching strategies that I've tried to apply. But there was another reason I chose this for y'all particular group. I work in primary care whenever I'm doing any kind of clinical teaching. And typically it's not life or death or critical. Time is an issue, but not as much as for many of y'all when y'all are teaching during a surgery. So this was the closest I can get to an example of what it must feel like for you as an attending or a supervising resident, or even as a learner, where things can get life and death pretty quickly, where the consequences of a decision or an indecision impact others. And so I'm going to use this as a way to talk about concepts and learning models, but apply it in a real world application. And as we go through this, I'm going to pause at times and ask for y'all to maybe share your own examples of, well, that model applies to when I teach students in the sim lab. So hopefully we can have some interaction virtually here. All right, so this picture was probably the first day, but this is actually more like how I look on many days where he's driving. I don't know if as attendings y'all ever have that look during procedures, but I have that look a lot when I'm sitting in the passenger seat. So what I've decided to do is pick 6 different articles or lessons that I've learned in the last couple of years and try to briefly highlight them so that you might have a takeaway that you could use later today or later this week. I'm guessing that as I talk about things, you're going to say, well, that's obvious. Of course, I do that all the time. And that's a great reflection on you. Maybe there's things that you're doing and you might not know conceptually the why behind it or how it impacts the learning. So maybe by going through and providing some of the cognitive structure behind it, you'll even tighten it up even more as you're doing some of your teaching. Let's see. So I put these up here, and there's a prerequisite to any of this, though. For teaching to really go well, it doesn't matter whether how you're giving the feedback or how you're assisting, whether you're setting up a learning environment in a certain way. Teachers have to be willing to teach. They have to have some kind of positive regard for the learner. There has to be a sense of assisting them along the way. And so if you're not able to be present and kind of meet the learner where they're at, we can talk about models all day and they just don't get implemented very effectively. And when I've heard some of the interactions with OB faculty with learners and how y'all approach that, it sounds like y'all really make an effort to connect with your learners to help bring them along. And I think that's one of the reasons why y'all do so well with recruiting and things like that. So I just wanted to give that caveat. It's a lot about the interaction between the teacher and the learner. All right. So I chose this first one mainly because I never get the opportunity to say Vygotsky or zone of proximal development. Those are big words. I'm from a small town in Florida. I don't usually use language like that. But basically what they're talking about, and this is obvious, for any of us, there's things we can do on our own. There's some things that with a certain amount of guidance we can do. And then as we move farther along, there's just things that it doesn't matter how much help we get, they're just beyond our capacity at this time. And so it's always helpful to try to gauge with your learners where they are on this continuum And sometimes that shifts just based on a particular patient or a particular time of day, that we can move up and down on that. But what this particular model talks about is trying to match what the learner needs with some of your interventions. So somebody who's approaching something that they are very unfamiliar with, that they just couldn't do it at all if you weren't there, they might need some more modeling or some direct instruction. Let me show you how I do this. Let me tell you how to approach this from this angle. And then as they get a little more confident, that's when you start providing a cognitive structure. So we're like, this is the purpose for coming in at this angle, for using this much pressure, for doing things in this order. And so they can kind of build the model in their head. And then later you're starting to ask questions as to, tell me why you're doing it that way. Here's some feedback on how you could do it a little bit differently. So I think that's a nice general model for thinking about folks kind of along 3 stages. I think in medical education, we've tried to use milestones and EPAs as a way to kind of gauge this. There's some real challenges to implementing those, but I think that sort of reflects being able to quickly gauge where somebody's at. From a driving perspective, you know, at the age of 15, that wasn't the first time my son had been behind the wheel. You know, we literally would sometimes say, here, hop on my lap. And my job would just be to do everything except he might steer a little bit. You know, he's just getting a feel for what it's like to hold the wheel while looking out. And then when we've had some opportunities for him to drive a golf cart, very isolated road, you're going very slow, just a little more feel. We went to Doctor's Hospital a lot, and there's just open road, very little traffic, so he could actually be behind the road. And the worst we're going to do is hit a curb and not hurt somebody. So that's where we started. And then lately we've started going out on the open road, and you know, it's scarier, but he's been behind the wheel longer. And over here on the right is Walton Way. And that to me is scarier than just about any road in Augusta. There's some places where it gets very narrow, and there's only certain times of the day that I'm willing to take him over there. So that is offering different kinds of assistance depending on where they're at. And there is a surgeon who tried to take some of that model and actually break it down to what the resident needs to do and the level of supervision that matches it. And these are very broad, but I think I like that there's a model to it. And if it's made explicit, then oftentimes residents will and learners will automatically start either thinking aloud or explaining the rationale for why they're doing something without you even having to prompt, because they know by doing that, you're more likely to move farther down in offering them more autonomy in what they're doing. So this may be an article that's worth going back to and discussing amongst your group. And let me pause there, see if anybody has a comment or question on this or this particular model.
Ralph, I'll just say I really liked this article when I read it. You know, we talked about it a little bit when I came over to the EII Teaching Fellows group. And it's really nice when you get residents to a point where you mostly only have to offer dumb help in the OR, which is what I got to do yesterday. I did a bunch of minor cases, and mostly Katie and Emily only needed dumb help at most. There was one part where we had to take out the ovary and avoid the ureter. So I gave a little more smart help there. But I think sort of reading through this list and then seeing how that plays out in action on the right, like what the behaviors actually are equal to, that's helpful for me as a teacher.
Thank you, Dr. Allen. I think you raised something that these models don't always take into account, that on certain aspects of that surgery, you could offer dumb help. And then there was other aspects that you were going to have to show and tell or offer more smart help. So oftentimes there's learning that's happening at a dozen levels. And so you may have to be shifting back and forth in the level of intervention that you're doing. So I think that's really important. So I was just starting to get good at giving feedback. I mean, this is the bread and butter of medical education. And I finally learned how to set it up, how to, engage the learner as I'm giving feedback. And Matt Tews, emergency physician, also runs the simulation lab. He goes, well, debriefing's where it's really at. I'm like, okay, tell me about that. So this is a really good article by Rudolph that walks through some of the differences between feedback and debriefing. And from my perspective, the real difference is that feedback, there's a goal behavior, and then there's an observed behavior. And part of your job giving feedback is to point out the discrepancy and what you think they need to do to get closer to the goal behavior. So there's an explicit goal, there's an observation, and then there's a comparison. Debriefing, and this doesn't need to be at the very end kind of debriefing, but part of the purpose of debriefing is to try to understand what were the thoughts, the feelings, the assumptions that the learner had as they took an action. With feedback, it's more corrective. With debriefing, it's trying to understand, well, what's the reason you chose to skip that particular part of the interview for a wellness visit with this mother? When I'm working with some learners, a lot of times they'll skip talking about alcohol or substance abuse with somebody who's from a certain part of town. And if I was just to give them feedback, with all patients, you need to do a good social history. That's not going to get at what prompted that particular learner to decide not to ask the 65-year-old woman who is dressed in a certain way about her alcohol use, or her using medications not as prescribed. I've learned the hard way that when I skip some of those questions, I'm often missing some substance abuse going on. So if you understand that, well, she looked too much like my mom and I just couldn't ask her those questions, the teaching is going to shift versus somebody that says, I never get any hits when I ask that question, so I just try to be faster. Those are going to be different kind of teaching moments for when you do that. So I don't have a particular example for my son with that one. We'll do a couple more and then I'll pause again for some comments. This is particularly used a lot in the simulation area, where there's an opportunity just for the interaction to happen and then a quick debriefing. So what was going on in the room? What were some of your assumptions as you went for that particular approach? So my training as a psychologist, as well as early on as a teacher, was behaviorism. Carrots, sticks, M&Ms, and that's worked well for me. And there's a certain amount of importance to being reinforcing, giving consequences for certain behaviors of learners, but it's not sufficient. And the reason for that is health professionals, it's not enough that they just mimic what their mentors do. They have to gain a sense of understanding for what's going on. They have to be creative at times when the situation doesn't mirror exactly what they just learned, that they have to begin to think on their own, to go through clinical reasoning that's beyond what they were reinforced for. But let me just give that caveat. There is a place for behaviorism and structure and rewarding certain behaviors that you get to go in on a more complicated procedure. If you've demonstrated something earlier and you've done your readings, you're not allowed to if you didn't, but that's not enough to get a professional from being a third-year medical student onto a fellow and onto somebody who can practice on their own. So constructivism is basically the idea that learners build knowledge. And many of us fall into telling information or, like adding Lego blocks to create somebody's knowledge base or their understanding of something. And that often implies that the learner is passive, that you can start at any one place, and that you can just keep adding on to it. And what they've learned from learning science is that we come into every situation with assumptions. When somebody's coming into the clerkship with y'all, and they've had certain rotations in advance of that, they're making certain assumptions about how clinics run, about morning report, how presentations are given, and they're going to start at that place. And if you don't have a sense of understanding where they're coming from, it's going to be more of a disconnect as you're trying to teach them. So if you understood that they just came off of internal medicine or family medicine, and they do their histories this way, you may need to say, that's fine, but for us, we like to emphasize a little bit more about this, and our presentations tend to be this long, and we start with this information. One of the biggest complaints we hear from third-year students is, I just have to guess what my attending wants me to present on. And as opposed to the attending saying, I know you've been taught to give presentations this way to cover everything, but we need a 4-minute presentation in this order. And that even varies by attending, so we'll touch on that in a minute. So telling information versus building information. There's a time and a place just for feedback and telling, and then other times you want to build on what they're trying to understand. So coming back to teaching my son to drive, here are some of the assumptions he had about the world that he wasn't directly explicit about in the beginning, but over time I kind of learned this, and a lot of it's because he does games, virtual games. And so he kind of assumed that cars drive the way they do on these video games. And so he was going through turns and kind of assuming that he could carry speed through it because he could just drift through the turn. My minivan doesn't drift very well, so he learned that pretty quickly, particularly as I was clutching the dashboard. I also noticed that he had 2 speeds. He was either pressing on the gas or pressing on the brake. And that works really well when you're on an open track going 200 miles an hour in one of these video games. It doesn't work very well when you're in town and you've got passengers. So it was really jerky how he was driving. So I needed to kind of understand where he was coming from as he did that. And then this might be all teenagers just want to drive as quickly as possible, and not necessarily looking for opportunities to let somebody over who's trying to get in, doing some defensive driving. He had kind of a competitive approach to driving, which is also very scary. So let me pause there again if anybody wants to comment on feedback and debriefing, or this concept of telling information versus building. Okay. So this particular article, I happened to see the author. It's one of the few times going to the National AAMC conference where I go to a session. I'm like, wow, this was really enlightening. I knew this, but this is a study where they interviewed residents and they asked them, as you progress through your training, how did you learn to navigate how the different attendings wanted things done in the OR? And they talked about one of the challenges is trying to figure out when an attending says something, is it a principle or is it a preference? So is when they tell you that you need to suture in this way, or that you only do things in this particular order, is that based on the literature and experience and all the attendings would approach that the same way? Or is that something that is supported with the literature as well as other approaches? And because that particular attending is left-handed and doesn't really like certain tools, goes through and does it this way. So it's very difficult for a first year to distinguish between principles and preferences. And as somebody gets on to second, third year, more advanced training, they're beginning to try to anticipate, oh, with Dr. Ray, this is the way he likes to operate with things. With Dr. Latif, she's going to ask me to do it in this way, and it's simpler for me to kind of accommodate my attending. The other thing this article talks about is every attending has a threshold for their willingness to be challenged or asked, can I do it this way? So somebody maybe want to approach a technique from a different angle, and they need to learn that different attendings in different settings or different points in the procedure would be okay with saying, I'd like to try it this way, or would you mind explaining to me how you made the decision to go in that direction as opposed to this one? It's a fine balance that learners are trying to respect the hierarchy as well as try to internalize and understand what's being taught to them. Is it a principle or a preference? So for this one, some of these are things that have come out of my mouth in the last few months. I avoid the suicide lane. I call it suicide lane. It's that middle lane on a where there's only one road on each side and then a turn lane down the middle. I told my son, you don't spend hardly any time in the suicide lane. That's where accidents happen. You're going to get hit from behind. Somebody's not going to see you and get you from the front. You want to spend as little time. Is that a preference or is that a principle? And let me just hear from somebody what they would say.
Preference.
A preference. Okay. So I always thought it was a principle, but when I talked to some different people, they're like, no, it's better for you to spend a little bit of time in the middle lane than to try to dart in from the side when you have a smaller opening. So there's definitely some times where they need to spend more time there. So probably a preference, but there's definitely a lot of folks would say you don't want to spend lots of time there, but it's a preference. 1 car length for every 10 miles per hour. You're going to see that in driver's manuals, driver's ed class. This is just some pretty common. You hear this. Is that a principle or a preference?
Principle.
Okay, I appreciate somebody volunteering for that. I think it goes closer to a principle. There's certainly times where I don't do that. And so then that is really confusing to my son when I state something as a principle, and yet we're, driving down Washington Road and we're late for a soccer game, and I'm only 2 car lengths behind somebody and we're going 40 miles an hour. It creates a discrepancy for him. It's like, wait, what are you doing? You're going 40, you're 2 car lengths. And so then what he'll end up doing is later, he'll go 40 miles an hour, be that close, and he can't understand why I'm telling him not to. So you might say, for you at this level of training, consider it the golden rule. It's principle. But over time, there may be, with more practice, then we may loosen up on that. But it's got to be explicit, otherwise it gets confusing. And then lastly, no texting and driving. So in our family, they just have an understanding that if they're caught texting and driving, that they won't be driving for a period of time, or that they won't be able to bring their phone with them the next time they're in the car. That for us is a principle. But then I got caught at a red light checking a text. And so they're like, wait a second, is that you're breaking your rule? I'm like, well, it's when I'm not actually driving. I'm at the light and not moving. And so I called it a principle, but I didn't necessarily follow it as a full 100% principle. So let me pause there and see, in either the outpatient setting or inpatient setting, can y'all give me an example of what you would consider one of your principles? Let me make it a little bit easier, for the sake of time. When do you start talking about sex and protection with your patients, your younger patients? Is there a guideline for that? Is there sort of a group understanding that at age of 11, that's when it starts? Or does it really vary by attending or patient?
That's probably very variable.
Okay. So there may be guidelines. I was just hearing about HPV vaccinations in South Carolina, how they've gone up. I saw a lot of variation within our clinic on recommendations to teens and older I guess they call preteens, the 9 to 12-year-olds, who was recommending that the HPV vaccine for them. It was clearly a preference. And yet in our clinic, we've now made it a principle for some things that we're just going to any patient who describes some depressive symptoms, they do a PHQ-9. It's a rule, it's an expectation, and we give feedback whether they are doing that or not. So that would be an example of a principle that our practice has agreed to. You may disagree with the established principle and consider it the preference of the group, but for learners, they would see that as a principle. And
Ralph,
Bill,
I can give an
yes.
example. So it's always been a principle that at the beginning of a surgery, if you're doing an abdominal, pelvic surgery, that you prep the patient for sterility, right? That you reduce the bacterial burden and reduce the incidence of infection. So, and we usually always prep in general the same way with the same substance. So that's a principle. However, we have noticed recently that there's been an uptick in infections in GYN cases, and we've actually just changed our policy so that the vaginal prep is no longer betadine but chlorhexidine. And so that's a change that everyone's getting used to. But it's a slight change in principle. You still prep the patient. We're just using a different substance.
I appreciate that example. I think it also reflects the importance of feedback versus debriefing, because if folks were, and I'm assuming there's a certain amount of time that you're needing to clean the area, that if folks are doing it for just 5 seconds and you're supposed to do it for 15, trying to get an understanding as to how they chose to do it for only 5 seconds. The OR was getting backed up, or I've seen my attending only do it for 5 seconds, so I didn't think it was really necessary to do it that much longer. It changes the teaching moment versus somebody who's like, I just wasn't paying attention. So thank you for that. So I'm going to get on the soapbox for a little bit. So I have learning styles crossed out because I don't want to leave you with the impression that there are learning styles that are ingrained. So even though I'm talking about it, there's just not a lot of support for it. There is a lot talked about that I'm a kinetic learner, or I think more in verbal ways. I have to hear it through first, or I'm a visual spatial learner. I need to see it within a certain domain. I don't do well in groups. I'm a one-on-one learner. And so the problem with that is when somebody identifies a certain way, there's oftentimes an expectation. Well, here, let me back up. There's an expectation that you're going to accommodate that. And that's oftentimes not realistic. And what the literature shows is that we may have preferences, and there's certain types of modalities that enrich the learning, but that humans are really very adaptive and tend to be able to learn in multiple ways. Now, if somebody has dyslexia, it's going to make sense that reading content is going to be much more difficult than doing it as a demonstration and observing it. So there are caveats to that, but that's not necessarily a learning style. That is somebody's background influencing their ability to learn. So if I'm going to get on my soapbox now, is I liken this to when somebody says, I'm a Sagittarius. I like to get along with people. It's all good, that might be true in some contexts, but there's others where I'm not very nice, or I'm grumpy, So we are much more flexible. And I didn't even learn until I pulled this image up, as there's actually other signs within, there's you're a Sagittarius, but what's your moon rising? Oh, you're a fire sign. And the idea is that now the teacher has to kind of match what's happening with the learner. And it just cracks me up that somebody has gone and tried to generate a compatibility. So my wife is a Taurus and I'm a Sagittarius. We got a 30% compatibility. And that's kind of scary to see that. So it's just not, the evidence isn't there. And the article I included, I wouldn't wish anybody to have to read, But if you get really interested in this, it is a very detailed review of all the literature on what supports learning styles. And it's just not there. But it's very popular within medical education to talk about learning styles. So what is accurate about this? Oh, here's one more soapbox. I don't know if any of y'all have seen this pyramid before, talking about how little people get from a lecture or from reading something, but they retain things so much more in a discussion or when they're practicing something. I've seen this pyramid probably 100+ times. Anything fishy about those numbers? I'll do that as a rhetorical question. I will let you know that never in behavioral science is something that linear. And after doing some investigating on this, this was something that a professor put up as an illustration just to get her students to try to understand the importance of being more hands-on versus lectures. But she made up the numbers. They're ballpark, but because individuals, particularly as they advance in their training, can get a lot out of a lecture, because the really higher achieving students are actually doing things inside, sort of thinking, how does that apply to this other piece of information we got last week? Or they gave that example, but how would this work with a patient who's morbidly obese or with somebody who has diabetes? And they're already kind of doing that mental gymnastics even during a lecture, so they may be retaining more as a result of that. But what you can get from this is that the more you are moving towards the real world application and actually engaging in the process of learning, the more gets retained. So I tend to be a lot more motivated to stay engaged if I'm practicing something versus sitting in a lecture hall. And so from my son's perspective, if he's going to driver's ed class and they're talking about driving, that's really different than going down the road at 60 miles an hour and you've got multiple things giving you feedback. There's an opportunity for immediate feedback. You make changes, see what that works, and you build on it to the next level. So that is my soapbox for learning styles. How are we doing on time? Okay, one last thing, and then I'll give some opportunities for folks to offer some comments or observations. So this has always been important to learning, but it's not until lately that we really are beginning to recognize what can impact a positive learning environment. Just in the last few years, the Me Too movement, the Black Lives Matter, physician burnout, wellness, all these different things are trying to look at, the environment that an individual is in impacts how they interact with others, and how well they learn. So having a culture within your program that is positive and nurturing really makes a difference. And there's some departments that have been known to be a little more gruff and aggressive, my way or the highway, and people have succeeded in those environments. But then there's a lot of folks that have suffered or not made it through that who definitely could have. So let's talk a little bit about that. So it kind of makes sense, but what's one of the reasons for that? And I'm infatuated with learning about the amygdala. My specialty happens to be around anxiety disorder, so that's not unexpected. And for those who know a lot more about the sympathetic nervous system and brain anatomy, I'm going to grossly overgeneralize this, but basically fight or flight, scanning for threats in the world so that the individual can be prepared to handle that uncertainty, to handle that risk. And so it's constantly scanning. And so when you think about a positive learning environment, if things are uncertain, if there's biases that are going on and the person is that me? Is that just because of the color of my skin, or is that because something I said last week? Is it because of a political comment I made earlier in the day? If you're constantly scanning like that, it's going to be very difficult to take in information that's being talked about or during the debriefing to trust that this individual has your back. So the whole goal of the amygdala is to reduce risk and exposure. And so as a result, your cognitive flexibility gets restricted. Your willingness to try different things gets restricted. And that's not what we want in a learner. We want a learner who's willing to recognize the consequences of trying different things, but is also willing to trust that their teacher is going to make sure that they don't do something too drastic and have large consequences. Just asking folks in here to volunteer to say something takes a certain amount of risk, maybe not a lot, but for a more junior learner to say something, it starts to pique that amygdala a little bit. So anything that the program can do that fosters, no, we want to hear from everybody. Matter of fact, let me start with asking, what's the perspective on principles and preferences from our interns? And if it's a safe environment, they're going to share more about it. So one of the things I've been impressed with y'all's department is this sense of continuous professional development. And I'm not just throwing that out there because that's a new additional words to my title, that there's this sense that we can always get better at our craft. And so whether it's how y'all do procedures, how you teach something, how you develop your learners or your faculty, that y'all are doing it as individuals, but also as a program trying to support one another in, let's take it to the next level. I think Dr. Ray even started with that with his role, that he wants to help take y'all to even better than what y'all are currently doing, which is great compared to many departments. And that there's an intentional plan to it, figuring out if we don't have the resources here, where can we get them, evaluating that, and then the sense constantly of, okay, that's worked for that one, where else do we need to apply it? And there has to be, and remember what I started with, that positive regard, that willingness, that sense of having clear expectations. This is where it comes into play, that if your program has that culture, then individual learners are more likely to adopt it, and that as you're kind of struggling to make that next leap in that zone of proximal development, you're more okay taking risks because those around you know what you're doing. Like, oh, you're trying to do more laparoscopic surgery in this particular region, and that's new for you. Of course, you're going to need a little more time reviewing that. So I commend y'all for having made a commitment there. I was thinking about y'all having I believe y'all have a boot camp for fourth years who are going off to internships. And that's just a great example of kind of recognizing what are the needs of an incoming intern, how can we help folks do that, getting some of your first or second years to participate in that. It just creates that cycle of helping the professional at every level help them get to that different part of the circle that they're at. I'm going to pause there and see if y'all have any last comments on this cycle, on positive environment, or anything else that I had talked about today. Y'all do recognize that I'm a psychologist, and psychologists are very good with pauses. So I'm open to hearing some comments or reactions to the content.
I'd like to thank you for the presentation. In the beginning, you mentioned that some of the material, we'll think, hey, I do this already. But I think having a little bit of the background and the understanding as to why we do some of the things we do and why we should do some of the things has been really helpful. So I appreciate your presentation and your time.
Thank you for that. You just modeled an example of having a little bit of a cognitive structure behind certain actions, helps you kind of understand why you're doing something, and the next time the case comes up, you're going to go, oh, let me emphasize it in this way because I think it's going to land a little better. So yes, thank you for the comment.
Anybody have any other comments or questions for Dr. Gillies? If not, I'll definitely take an opportunity to say thank you again. I look forward to collaborating with you in the future. If you have any parting words, we'll welcome them, and
Okay.
if not, we'll adjourn.
Okay. Dr. Ray had mentioned some resources at the faculty development homepage. I'm going to forward all the articles over that y'all could choose to look at it more in depth later. But the Medical Educator Minute is something that I've recognized that as busy clinicians, even if I send out a 3-page article, the likelihood you're going to have the time or the desire at the end of the day to read it is it's challenging. So this Medical Educator Minute is my effort to pull out some key pieces, maybe 3 take-homes and a little bit of summary that you could look at maybe in a minute. It's 1 page long, but then there's a couple more references towards the end that if you want more, here's the original article, here's some other references. So that's something y'all might be able to use, as you said, in your faculty forums or other settings where it's like, let's do a quick teaching moment. Let's review this. It's good fodder for discussion. So that'll be my last plug for the morning. But I do hope to get to interact with y'all some more down the road. Thank y'all for your time this morning.
Thank you.
Thanks, Ralph.